Yes, ma'am, you are audible. Good evening.
Good evening. Um, just give me a minute. Let's see if someone is unmuted. Welcome to the Neurosurgical Case Room. This is a continuation session of Vestibular Schwannoma. And we are going to cover some more boring stuff. I can't help that. The topic is dry. But let's try to make the best of the situation. We will begin where we left yesterday. We did the Hanover grading, which told us about the size and the classification of the vestibular schwannoma in terms of, the structures it is affecting. Today, we are going to cover the Koos grading. And then, as I said, we are going to spend substantial amount of time on the investigations, especially the PTA, because that is a sore point for a lot of residents. Let's start from Hanover grading so that if we have something to connect back to. We did these yesterday, right? T1 is purely intrameatal. T2 is both intra and extrameatal. The tumor, in fact, let me draw, for example, this is the internal auditory canal. Okay. This here is the internal auditory canal, and assuming we have the brainstem somewhere around here. This is space that you see in between. This is the CP angle cistern. This white thing filled with CSF. Now we know, let's imagine the classification here. We do have the radiological image that you saw yesterday. T1 is going to be this purely intrameatal, right? This lesion is not going to leave the internal auditory canal. T2 is going to go right outside its bony opening, somewhere around like this. T3 and T3B, A and B both, they are cisternal components. What do I mean by cisternal components? They are going to run around the CP angle cistern, but they are not going to compress or displace the brainstem. So if you follow along my color coding, you can see T3A, which is sort of filling up this white space, which is the CP angle cistern. And if you see, let's color code here as well. If you see T3B, it reaches the brainstem. So this lesion is going to be here, right at the periphery of the brainstem without compressing or displacing it. T4A, interestingly, please keep yourself muted. This is going to interestingly compress the brainstem. And if I draw T4B, then it is going to severely displace the brainstem. What do I mean by that? You will see in the further radiological images. This is how it's going to look like. T1 is purely intrameatal, right? T2 is both intra and extrameatal. You can follow the color coding around. T3A and T3B. Remember, both of these are cisternal components. They are both cisternal. They are both inside the CP angle cistern, outside of the meatus. T3A only fills the cistern. T3B reaches the brainstem. It does not yet start compressing or displacing the brainstem. When we talk about T4B, group it in your head for remembering that this is the brainstem portion. T4A is going to compress the brainstem. T4B is going to severely dislocate the brainstem. Are we all on the same page?
Yes, ma'am.
Okay, let's move to the next image that you all saw yesterday. I'm not going to go over this again to save the time. This is Koos grading. It's also similar. The concept is similar, the grading is different. you can see that there are 4 grades here instead of 6. The only difference is Koos 3 is roughly, if you can see, this is the cisternal component, right? Koos 3 is roughly Hanover T3, but Hanover T3 was divided in A and B. Koos 3 is not divided in A and B, but you can see that it is more or less cisternal. Just give me a minute. So if you look at it again, you can see Koos 1 is again intrameatal. It's not exiting the meatus right now. Koos 2 is, it is exiting the meatus. Koos 3 is where it is filling the CP angle cistern, and Koos 4 is, it is displacing the brainstem. Let's look at the theoretical Koos grading. Grade 1 is a small intracanalicular tumor. Grade 2 is a small tumor with protrusion into the CP angle cistern. There is no contact with the brainstem. Grade 3, the tumor completely occupies the CP angle cistern, but there is no brainstem displacement. Grade 4, this is a large tumor where you will see the displacement of brainstem and the distortion of cranial nerves. Then we come to the diagnostic evaluation. Let me see. I have divided diagnostic evaluation in 2 or 3 different sections so that it would be easier to remember instead of having a lot of cognitive load. One section of investigation is going to be primarily diagnostic, especially imaging, and the other would be auditory. And when I say auditory, I am including the vestibular investigations into it. The third one is going to be, which is probably one of the most significant ones, is the specific investigations that we need for our pre-op planning, without which we cannot decide on our approach or on our surgical limitations. So with that in mind, you can take a look. If you keep that division in your head, it's going to be a lot easier. When we talk about gold standard neuroimaging, we all know that we will need high resolution MRI brain with and without contrast. And if you have access to it, if your institute has it, ideally you should have CIS or FISTA imaging. Why? Because this sequence is going to be specific for all the neurovascular bundles around there. And you would need a DWI sequence primarily to differentiate it from CPA other differentials like epidermoid cyst or arachnoid cyst. You usually would not need DWI primarily for this, but it's a good sequence to have on hand. When we move to audiological and vestibular section, we have PTA, the pure tone audiometry, and we have the speech discrimination score. We will take a lot of time in discussing this, but let's just go through the names first. Patient is going to have this ENT evaluation, getting PTA done, then the speech discrimination score, then they will need BEAR or ABR if your institute has the facility, and the ENG or VNG. Now, let's break down the pure tone versus speech mismatch. What do I say when I say there is pure tone audiometry? There is going to be a single beep. Instead of, a barrage of sounds, there is going to be a single beat at different frequencies. And like the beat you hear when you pick up the phone, the old school phones, and there's this tone, that is the pure tone. The speech is, I think, self-explanatory. Some said words are going to be there, and the classic mismatch is the patient will be able to pick up on pure tone, the single beeps. If pure tone is complicating your concept, remember that these are single beeps. Patient is going to be able to hear these beeps, but they will not be able to understand spoken speech. What I mean by that is, for example, assuming you have a patient who does not hear anything at all, then that patient usually has an age related or noise induced hearing loss because they cannot even identify the sound, right? What the sensorineural hearing loss is going to do, let me write, the tone is going to be preserved. Patient will be able to pick up the beeps. The problem will be in the speech discrimination. They will have a hard time in recognizing or separating the words. Am I making sense? Am I audible?
Yes, you
Yes, ma'am.
are.
Okay. So is it making sense?
Ma'am, if you could please repeat it.
Okay.
Thank you.
Okay. This is probably the most important concept you are going to take from this session. Have you ever heard that single beep, like a simple beep when you pick up the old intercoms or phones, or even when you call somebody and there's a single ring, right? A single pure tone.
Yes, ma'am.
That is a single beep. Speech mismatch is when the patient is able to hear that beep, but the patient cannot understand the speech. What happens is, as a patient is getting older, or if there is noise induced hearing loss, there will be a problem in listening to this as well. They will not be able to hear the pure tone because they are not able to hear it primarily. Obviously, they will not understand the speech. So, for age related hearing loss or noise induced hearing loss, the pure tone, I'm only going to write PT, is going to decrease, and the speech understanding or the speech recognition is also going to decrease. Is it clear so far? Because if this is not clear, you will have a harder time in understanding the mismatch. Let's go through it again. If the patient is not able to hear the sound understandably, the speech understanding is going to go down as well, right? If you cannot hear anything, you would not understand what the person is saying. This is what happens in the age related hearing loss. So, this is proportional. For sensory neural hearing loss, they would be able to hear the sound, right? But they would not be able to understand the speech or to discriminate separate words. Like I'm talking right now, you can hear the sound, but you can also understand the words, right? For a patient who has sensory neural hearing loss, my voice would probably sound like only a sound and rest of it would be gibberish. Like they would not know what I am talking about despite knowing the language. Let's look at another slide. So when that happens, there's this distinct split. The PTA is going to be relatively intact, or there is, even if there is loss, there is going to be mild to moderate loss. But speech discrimination score is going to drop significantly. They would be able to hear, but they would not be able to discriminate what is being said despite knowing the language. Is it making some sense now?
Yes. Yes, ma'am.
Okay. Okay, let's
Yes, ma'am.
move on.
Thank you.
Why is that? The next question that should follow this is, why is this happening? The problem is because cochlea is our hearing organ, right? We all know that. Cochlea is our hearing organ. Now, this organ is intact in sensory neural hearing loss. Where is the problem? The problem is in cranial nerve 8, the vestibulocochlear nerve. What happens is the cochlea is detecting the sound, but the nerve was responsible for making sure that the sound reaches the brain and that the sound is interpreted, right? So if there is a problem here, the sound is being perceived, but it's not going to be perceived properly. So the words, they get scrambled up, they sound like gibberish. The sound may be loud enough to hear, but the brain signals, they get garbled. And what is the telltale sign? Even if you turn up the volume, which works in, let's say, senile hearing loss, I'm sure you all would have family members, grandparents, or even some patients who come with senile hearing loss. And for them, if you talk loudly, they would be able to hear you and they would be able to understand simultaneously as well. So, turning up the volume, it works for senile hearing loss or for noise related hearing loss. This is not going to work for sensorineural hearing loss. It's only going to overload the nerve. Once the nerve is overloaded, then the brain is not going to receive the signal properly. Is it clear now? I think you're all pretty lost. Uh, I would suggest to go down and listen to the session again so that it ends up clarifying even better. Let's move to the Gardner-Robertson scale. To understand the Gardner-Robertson scale, you need to remember the previous concept. What was the pure tone? The pure tone was just a beep, right? And what is the SDS? The SDS is speech discrimination score. You are asking the patient to describe the words they are hearing. So, what is this dB number is going to signify? This decibels mean the loss, the total loss of, uh, it simply means the loudness loss. How loud a simple tone must be before the patient can detect it. So, if the loss is less than 30 decibels, it is good. It's normal to very mild loss, and sounds only need to be slightly increased in volume, more than normal conversation levels to be heard. 31 to 50 decibels means serviceable. This is moderate loss. The sounds, they need to be played louder, and if you want any meaningful speech to be understood or recognized. 51 to 90 decibels, this is non-serviceable. This means that the patient has severe loss, only loud sounds or shouted speech are detected. More than 90 decibels, they mean there is profound deafness. Please remember this is a measurement of loss. So if there is a loss of more than 90 decibels, this means minimal to no tone perception remaining at all. This is our classification. You can see that Gardner-Robertson scale is classified in 5 different segments. There are 5 classes. Class 1 is excellent and class 5 is non-functional. The easiest way to remember any classification. Class 1 is excellent. Class 5 is completely non-functional. What do we mean by excellent? The decibel loss is less than 30. And the speech discrimination is good. You can see that the patient was able to recognize whatever was being played or said, 70 to 100% of it. So the speech discrimination score is good, 70 to 100. The loss is less than 30 decibels. So this means near normal volume and clarity. This is class 1. Class 2 is the hearing is serviceable. What do you mean by serviceable hearing? There is a loss of 31 to 50 decibels, and the speech discrimination is 50 to 69%. This means, for example, whatever I am saying right now, you only understand 50 to 69% of it. That is useful hearing, but this is still problematic. It's class 2, it's serviceable. You can do something with it. Class 3 is non-serviceable. How much is the loss? The loss is 51 to 90 decibels, and the speech discrimination score is 30 to 49%. poor volume and poor clarity. Like if somebody has network issues right now, they would only hear partial things, and that too probably would sound like gibberish. Class 4, the grade is poor. PTA loss is more than 90 decibels, and the only speech the patient understands is 0% to 29%. This means there's profound loss. There is tone detection, but it's barely present. Class 5 is you cannot, and the patient cannot even hear, or it's unmeasurable, loss of pure tone average, and there is 0% speech discrimination. It's easier to remember these charts if you assign something to these percentages. Like when I'm saying speech discrimination score 70 to 100%, this means that the patient is understanding only 70 to 100% of the said speech. So if you assign these, uh, you know, uh, sentences to the classification, it's going to be a lot easier to remember. So I'm sure you all know this rule. To qualify for serviceable hearing, class 1 or 2, under the classic 50-50 rule, a patient must meet both criteria: a PTA of loss of less than 50 decibels and a speech discrimination score of more than 50%. If either metric falls below, then the ear is classified as non-serviceable. Then we have the AAO-HNS classification. It's something very similar, but there are 4 classes instead of 5. Class A is, this is again the loss of less than 30 decibels, and speech discrimination stays more than or equal to 70%. Class B is loss is more than 30 decibels, speech discrimination is more than 50%. This loss stays between 30 and 50 decibels. This is the serviceable group or the salvageable group, where the hearing is salvageable. Class C, the loss is more than 50 decibels and a speech discrimination score is around 50%. Class D is the speech discrimination is less than 50%. Any time where the speech discrimination drops below the 50%, this becomes non-serviceable hearing. I would ask on the feedback poll on the WhatsApp group whether everybody who listened to this classifies in class B or C. How much was the speech discrimination score for this session? So for pre-operative surgical planning, we have we know that we want this thin slice CT petrous bone. Why do we need that? Because we want to see the osseous anatomy in detail. Partly, we want to see the thickness around the semicircular canal. We want to see the mastoid pneumatization. We also want to see the state of posterior internal auditory canal wall, whether there are erosions, whether the wall is thinned out, if there is any variation in jugular bulb height or exposed carotid canal, etc., etc. So you want detailed bony anatomy of the petrous region, and this is crucial. Ideally, you should not be selecting your approach without CT petrous bone. And yes, MRA, MRV, why do we need it? We need it because we want to see whether the ICA is following the typical anatomy or there are any variants, whether there is an intrameatal loop which is long. We also want, ideally, we want the DTI as well, because we want to track the facial nerve along the tumor capsule. If it's a large tumor, especially more than 3 centimeters, it's cystic, the anatomy is atypical, then DTI is going to help you track the facial nerve before even touching the capsule itself. We are going to look at some interesting radiology cases, and then we are going to conclude this session. Tomorrow we will do management session as well. So can somebody go over this scan for me, please? Anybody? It's easy enough. Nope. Apparently, the speech discrimination score for today's session is very low. So this is a cystic schwannoma. It's an MRI brain with contrast axial image. And what you are seeing here is a well-circumscribed lesion in the left CPA, which is showing heterogeneous intensity. You can see it arising. The origin is from the internal auditory canal on the left side. And the lesion is completely filling up the CPA cistern, also compressing the brain stem. I would not call this displacement. I would say that this is compressing the brain stem. Apart from that, you can see that the contrast uptake is heterogeneous. There is a visible cystic component within the lesion here. So this here is the cystic component of this lesion. Rest of it is solid. This is a beautiful, beautiful sequence showing us these are axial images and showing us the beautiful anatomy of CP angle cistern along with inner ear. You can see the semicircular canals here. Let me turn on my marker. You can see the semicircular canals. You can also see the cochlea, and this here is the internal auditory canal. It is beautifully visible, and I am not sure if it is visible on your screens. It is on mine. There are two nerves that are coming outside, the facial nerve and the vestibular cochlear nerve. This entire region here is the CP angle cistern, which is currently being traversed by these nerves. And let me mark here. This is the basilar artery. And what do you think is going here? This is our ICA, beautifully visible. This is a very classic case of bilateral vestibular schwannomas, which characterizes this for, which is the condition?
NF2.
NF2. That's right. Bilateral vestibular schwannomas are characteristic for NF2. Very, very rare to see this huge. Usually, what you see is one very large vestibular schwannoma and the other is usually small. You can see that there is severe compression of brainstem going on. There is distortion of cerebellar peduncles as well in the coronal images. Tomorrow, we are going to discuss the association with NF2 along with the management protocol. How do we decide and what goes in the decision making? We will not cover the surgical approach separately because retrosigmoid approach was already done. So that's it for today. This is a wrap. It's to be continued tomorrow. Any feedback and questions are more than welcome. You can always leave it on the WhatsApp group if you were not able to ask directly. Thank you so much, everyone.